to start with the first one in this group is this picture is a very clear-cut one, and is a 45-year-old diabetic who has presented with painful leg and accompanied by fever. Discoloration started in the leg and ascended to the thigh. The patient is drowsy and dehydrated. Identify the disease condition. I think this was clear enough. With an immunocompromised patient with a disease that starts in the foot or the leg and is ascended upwards is probably a kind of a cellulitis, where, as you can see in the previous picture, there are formation of multiple blisters and there is a discoloration of the skin. So with this discoloration of the skin and with painful blisters, remember that the most important point always to understand is how to differentiate between a necrotizing fasciitis and a cellulitis. Remember that cellulitis is usually not associated with blister formation or a darkening or a discoloration of the skin. But the real difference between a cellulitis and a necrotizing fasciitis is usually done by a score that is called as LRINEC score. So if I ask me what is the disease condition, one line answer is a necrotizing fasciitis is the disease condition. The differentiating between an cellulitis and this disease by this picture is very clear because there are blisters that are shown along with the skin discoloration. The second question that asks you about is what is the classification of the disease that is based on the pathogen? That means the examiner wants to know, in a case of a necrotizing fasciitis, how do you differentiate or how do you make the groups based on the pathogens, based on the organism? This is more or less a standard postgraduate question. A type 1 necrotizing fasciitis is always polymicrobial. And when I talk about polymicrobial, there are various aerobic and there are various anaerobic organisms which are both seen. Definitely there is a synergism between these ones. There are facultative aerobes and anaerobes which are cultured together. The most common of these scenarios, this is the most common type always. This is usually seen in diabetics and other immunocompromised patients. And majority of these infections are either in the post-operative abdominal walls, particularly after a contaminated surgery, or they are sometimes seen in the perineum also. Okay, so remember Fournier's gangrene is a type of a necrotizing fasciitis. So to start with again. Now the type 2 of a necrotizing fasciitis is technically called to be a monomicrobial. Now by the term monomicrobial, this is very specifically done by beta hemolytic streptococci is the most common that has been isolated. These are usually seen in the limbs and the patients are known to be previously healthy rather than diabetics having them over the abdominal wall and the perineum. A type 3 is again a very specific one in which it is due to Vibrio vulnificus, which is a gram-negative organism. Remember, this is very specific of a marine exposure. That means exposure to the sea, whereas a type 4 is something that occurs due to an MRSA. So these are some things that you are required to know in this part. Now the last question is, what is the role of hyperbaric oxygen therapy? Hyperbaric oxygen therapies are typically used when there is a continuous progression of the disease in these patients. So what is very important, as I have told you about, is when there is a progression of the disease, hyperbaric oxygen therapy is an important one. But remember, the main management of a necrotizing fasciitis is always an aggressive debridement. So people will call this to be, if you are given an OSCE, what is the treatment of choice? Just one word, emergency, a radical debridement, which is combined with use of IV antibiotics. They should contain coverage of anaerobes as well as aerobes. Okay. Remember that if you have identified anaerobes as a factor and the patient is in a septic shock, or you feel that the margins are progressing despite your debridement, this is said to be an indication of an hyperbaric oxygen therapy. Though there are criticisms for an hyperbaric oxygen therapy versus amputation, but remember that again, this is a question that can be asked in that. Amputation previously had a low threshold, but given the good amount of antibiotics that we have now, amputation rates are still coming down. Overall, the necrotizing fasciitis has a mortality rate of around 20 to 30%. That is pretty high to remember. So these are all the things that you are required to know in this first question. Rudra, do I have any questions from the chat box?
No, you don't have any questions from the chat box. Just give 30 seconds. Let's see any new questions are coming or not.
So, ladies and gentlemen, I think that there is a new score that not new. This is there for last many years. Something called as LRI NEC score. You are required to know this score, the components of the score. Remember that anyone who has a score of 6 is known to have a necrotizing fasciitis, not a cellulitis. So it is good to know about this score. What are the components in this part? I think Rudra, if I don't have,
just wait. Okay, everyone, whoever wants to ask a question, please do so in the chat box when that discussion has ended, so that the professor can answer the question then and there. If you don't have any more questions, wait, Dr. Vivek has asked, can we say the role of, the questions are coming. Okay, Ramanuj, are you there?
Yeah.
Okay, Dr. Vivek has asked, can we say the role of hyperbaric oxygen as post-debridement use?
Hyperbaric oxygen, see, the question is very specific, role of hyperbaric oxygen post-debridement. Yes, you can, but this is a postgraduate forum. It will be better if you are more specific when you are going to use, particularly in type 2. This is more or less a monomicrobial, type 3 monomicrobial. In a type 1 where you have an anaerobic pathology, remember that hyperbaric oxygen therapy has its own set of problems. So this is again something that we have to understand. Number one, forget about the cost, because people have thought about that what is the outcome of this. Remember that there are lots of complications that are done, but they are still under a research process. People have, again, some people are in favor, some people are not in favor, but people feel that, as you have said very rightly, after debridement you can do, provided you get an anaerobe as a growth medium or in culture, and the patient is not coming out of the shock or the disease is progressive. So 3 points to remember. It will be more happy if the examiner is particularly more specific, asking something specific. So I think it will be that.
The next question is coming from, hello? Yeah, can you hear me, Ramanuj?
Yeah.
The next question is coming from Dr. Rishanki Agarwal. She's asking about the IRNIC score.
The LRI-NEC, so it is not IRNIC. It is not
the LRI. LRI is my mistake.
Okay, it is LRI-NEC score. Now, Dr. C, simple things, you can go to the net, you can search something called as, there are calculators to calculate the LRI-NEC score, but LRI-NEC scores has been a standard benchmark now for the last around 10 to 15 years, in which if you are confused about a cellulitis with a necrotizing fasciitis, or whether if there is any at all Fournier's gangrene or not, but remember Fournier's gangrene nowadays has its own scores. There are 6 components of the LRI-NEC score: CRP, WBCs, hemoglobin, sodium, creatinine, glucose. More or less, everything is very easily measurable. CRP, WBC, hemoglobin, sodium, creatinine, glucose. Based on this, definitely we are not computers. You feed it to a computer, or there are apps now that are used to calculate the score. Remember the name of that score, and remember that if there is anything that goes more than 6, it is a necrotizing fasciitis. Do not hesitate to go for a radical debridement. The more delay you are doing, the more that infection is spreading above or below the fascia.
Right. Dr. Harsh Agarwal has asked, can it present as wet gangrene?
Sir, these terms are gradually going out of the practice. Now, yes, you can say this is wet gangrene, but see the picture in the story, sir. Wet gangrenes and dry gangrenes are typically described as over the foot. Particularly, diabetic gangrenes were described as wet. Ischemic gangrenes were described as dry. Now, you can call this to be a wet gangrene. In the strictest sense, yes, I will not be saying no. But probably the modern term that we use now is a necrotizing fasciitis. Like, say, if you had said the word gas gangrene, well, that is the older word for this one. But remember, gas gangrene has its own set of pathogens like Clostridium, etc. Nowadays, we have removed all these terms to understand what is an NF. As I've told you, there are 4 types of NF: type 1, type 2, type 3, type 4. Okay. No more. Rudra, can I go to the next one? Hello.
Hello, Ramanuj. Sorry, I just
Yeah.
unmuted myself. So there are 4 more questions. If you can answer very quickly.
Okay.
Dr. Abs is asking how to administer HBOC and when to withdraw it.
How to administer HBOC? Sir, HBOC is administered in a special chamber. That hospital usually should have a special chamber to administer that HBOC. HBOC monitoring is a very important critical point. With the amount of the concentration of oxygen, which is usually very high concentrations of oxygen, the monitoring of the patient not only is the vital, but again, there are many safety precautions that you must take in HBOC administration. Now, talking about when to give an HBOC, as I've said, you should have an anaerobe culture. You should have the disease to be progressive, not responding to your debridement, and the patient is not coming out of the septic shock. But still, that is a controversial indication. There are no standard level 1 evidences to suggest an HBOC improves. There are multiple complications, including fire accidents, that can happen. Okay. Third question. Next question, Rudra.
I think you answered this question. Sanjay has asked components of LRNIC.
LRINEC. Just search the internet for the app, and then you will get that app. Okay.
Okay. Shall I move on to the next question?
Yeah.
Dr. Nagnamrata has asked difference between NPWT and HBOT.
NPWT is negative pressure wound therapy. That's a totally different thing, sir. That is something in which you apply a negative force on the wound by use of a machine that is constantly producing a micro and a macro deformation of the wound. That means it is basically like applying a vacuum cleaner over the wound. It's a simple way of understanding. And HBOT is making the room filled up with oxygen, 100% oxygen, so that the anaerobes are not getting anything to eat, or whatever they are, your tissue oxygen concentration remains the same. The atmospheric air will now change to near about 100% oxygen. So that is the HBOT is hyperbaric oxygen therapy.
Right. So Shailesh Kumar, Dr. Shailesh Kumar has asked gas gangrene and NF. What are the clinical differences?
Not great, sir. Not at all great. Gas gangrene is an old term. We have removed these terms called gas gangrene from our vocabulary now, except that some books will still continue to use this. All modern books in surgery will now be more happy with the term called NF. But still, if you are very inclined to use the term gas gangrene, remember that clostridial myonecrosis is a form of wound contamination, crush injuries, where you have to isolate clostridium. But again, as I have said, majority of them are polymicrobial and will come under type 1 NF.
Dr. Pallavi Jampa has asked, and she asked this question twice. Sir, can we tell HPOT for wound healing?
In this case, yes, you may, but hyperbaric oxygen therapy is for wound healing. Remember that, see the question. Understand the patient is drowsy and dehydrated. That means the patient is definitely in a form of a sepsis. The reason about asking HBOT is to wound healing. I think for saving the life of the patient should be the first target, and then thereafter wound healing will be the next one. So if the examiner wishes to not accept that answer, well, he or she may be right in his point. Okay. Other questions?
You are saying to avoid it.
Yeah.
What you said.
No. For wound healing, I will not be giving the answer to that. I will not be giving credit to that answer.
Right. Okay. Pallavi, I hope you have got your clarifications there. Okay, Ramanuj, please move.
Okay, this one. Now, this question I think is a straightforward one. I do not know how many of you have written the answer to this. This is, what is the pre-malignant condition that has been shown in the picture? So the pre-malignant condition is something called as oral submucous fibrosis. Now, this is something called oral submucous fibrosis. Now, if you have written leukoplakia or erythroplakia, well, leukoplakia and erythroplakia are patch and plaques, and definitely by exactly looking at this area, it is very difficult to comment upon whether it is a oral submucous fibrosis or this. So as an examiner, yes, you may have to be given that answer in a benefit of doubt. But usually in this type, if you can see the mucosa, particularly the inside of the cheek, this is technically called as an oral submucous fibrosis. Now, as I have said, if you have written leukoplakia or erythroplakia, which are velvety lesions or technically are plaques rather than patches, well, definitely we have to give you some amount of credit also. We will not be arguing with you that this is not a leukoplakia, this is a submucous fibrosis, because this is a two-dimensional virtual case. In a real world, remember that a erythroplakia and a leukoplakia are usually plaques rather than this. Now, how will you confirm your diagnosis about this disease and what is this pre-malignant condition? Now, as I have said, this pre-malignant condition is an oral submucous fibrosis. The diagnosis is usually confirmed by taking a punch biopsy from the area to rule out the dysplastic cells. And the vital staining that is done is usually using something called as a toluidine blue. Now, the main thing that toluidine blue does is that toluidine blue has known to have an affinity for DNA. Okay, so more is the DNA, that means more is the replicating cancer cells in the tissue. Vital stainings are those stainings which are done in living subjects. Like say, for example, a good amount of this is Lugol's iodine, okay, which are done in case of Barrett's esophagus, and or say toluidine blue in case of this one. So if you use toluidine blue, what happens is that the areas that have more amount of dysplastic cells are going to be more blue, and you can take a targeted punch biopsy from that area and send it for a histopathology for this. Now, what is the treatment for an oral submucous fibrosis if it is? Now, remember that oral submucous fibrosis is a very common disorder. This appearance that you can see technically, which is not like a red velvety plaque like thing, it is technically called as a marbled pallor. Okay, it is technically called as a marbled pallor or a mottled appearance. Hence, goes more in favor of a diagnosis. The etiology for this disease is chronic irritation due to chewing of betel nut and tobacco associated with a vitamin deficiency. The main problem in this is, number one, it is a pre-malignant lesion. What is the risk? Well, people have fought about the risk. Some people say 10%, some people have more higher percentages to quote about. When it is diagnosed, remember that the first part is a observation about couple of months with the factors being removed. If it is not removed, then a surgical excision followed by skin grafting. Now, if you talk about the role of lasers, unlike that of leukoplakia, the role of lasers are debated in this part. So this is all about toluidine blue. We have talked about what is vital staining, confirmation of diagnosis is done. Okay, so there are questions in this now.
Yes, Dr. Sham has asked, is oral submucous fibrosis associated with trismus?
Yes, it is associated with ankyloglossia and trismus. Ankyloglossia, if it occurs in the floor of the mouth, in this location, as has been shown, it will be associated with trismus if the disease progresses to an extensive area of the cheek. If it is small areas of the cheek, like in this one, may not be. Extensive areas, yes, it will.
Well, yeah. Dr. Shobna has asked, leukoplakia, erythroplakia are clinical diagnosis?
Yes, they are clinical diagnosis. Remember the WHO definition of leukoplakia. Any white patch or plaque on the surface that cannot be explained by any other etiology. That is a leukoplakia. Erythroplakia is a red velvety appearance of the mucosa which cannot be explained by any other cause is an erythroplakia, and so is an oral submucous fibrosis. But the incidence of malignancy in them are varied. Like erythroplakia is known to have a 17 to 20 times chance of getting into a cancer, whereas leukoplakias and oral submucous fibrosis are known to fall in the intermediate category. Okay, so leukoplakia, some people say I have around 5 to 10 times, 8 to 10 times. Submucous fibrosis are somewhat little less.
Dr. Shobna has asked the treatment of OSMF again in a short way.
Sir, 2 lines only,
Yeah.
as if you're writing an OSCE. Precipitating factors like tobacco, betel nut to be avoided. 6 months observation, rich diet containing antioxidants. If the thing is not responding to this, then an surgical excision with a skin grafting. Role of lasers are debated.
Right. Dr. Ravi and Dr. Alkama has the same question. Can it be methylene blue staining inside of toluidine blue?
Not very well. I am not very methylene blue in the oral cavity as a vital staining. Well, I'll not be giving you that marks because toluidine blue has a very strong affinity for DNA. Methylene blue, no, I will not be giving you.
Right. Dr. Shailesh Kumar has asked, submucous fibrosis and tingling sensation are strongly associated with each other.
With I could not understand.
He has written submucous fibrosis and tingling sensation are strongly associated, I guess, with each other.
No, well, see, that may be. Now see, they are not. Now, I do not understand the question, but yes, they may be. But it is more the submucous fibrosis. There is more of a clinical observation that you have. Now, the tingling sensation that can be due to many reasons, starting from a vitamin deficiency to a glossitis, etc. So I do not know how to correlate these two questions.
Dr. Pallavi has asked, sir, can you tell incisional biopsy instead of punch biopsy?
Yes, you can. Definitely, you can.
Great. Dr. Shobna has another query. If we have written leukoplakia in question 1, then question 2 answered.
Leukoplakia, then how will you confirm the diagnosis? Sir, again, it is by taking a biopsy. Leukoplakia is, remember all those epithelial changes that we used to describe in a leukoplakia. What are the epithelial changes and what are the changes that happen in a leukoplakia? Remember that clinically, as I have said, in histology of a leukoplakia, the telltale sign of a leukoplakia that you will be asked in a viva voce examination is parakeratosis and the retipegs are widened. Okay, so this is all about this part.
Right. I think.